I was asked to speak about maximizing SVR in 2015 with the current therapies. These are my disclosures. And the objectives tonight are essentially to try and go from the suboptimal response, which I put a suboptimal response at, say, less than 90%, and move into the more optimal response at about 95%. And I wanted to categorize a few different types of persons in whom we do have, I think, still a suboptimal response. One is the whole concept of the advanced compensated cirrhotic patient, who is very different from the decompensated patient. The patients who have DAA failures, genotype 2 and genotype 3. So compensated patients, compensated cirrhotic patients, not all cirrhotics are equal. And I put this example on here for about a 64-year-old fellow with genotype 1A, a FibroScan of 14.5, platelets 156, and albumin of 37. And then in the same instance, the FibroScan reading somewhat higher, platelets 88, and albumin 34. So if you think to yourself what regimen you're going to actually utilize, you might be quite surprised that in a number of jurisdictions, you'll be utilizing the same regimen for this specific patient. And these are compensated patients. But I'll get to the point where they might have to differentiate these two persons. So the first study is the Turquoise II data. This is the AVV3D regimen. And essentially only cirrhotics were enrolled into the study. It's for treatment naive as well as treatment experienced patients. And you see the genotype 1B and genotype 1A broken down separately. The one patient is the cirrhotic partial responder, which is from the whole phase 3 program, which is the only patient did not respond to this regimen. So essentially, most of the failures come from a genotype 1A person. And the labels are different within the US and Canada as well as Europe when you look at the duration of therapy. So let's take a few lessons from what this study showed us. I'll tell you the inclusion criteria for this study were FibroScan readings of greater than 14.5, platelets had to be over 60, and the albumin had to be over 2.8. So they're quite liberal with regards to the inclusion-exclusion criteria. So this is differentiating the SVR, and mainly driven by the genotype 1A patient by 12-week and 24-week regimens. And essentially you see in the darker blue and 12-week regimen, 91%, and then the 96% is at 24 weeks. And looking at different factors, we already said the genotype 1A person will likely respond somewhat better to the 24 weeks, acknowledging there are wide confidence intervals. I want to pay special attention to the platelets less than 90. And you can see that the response rate in the 12-week course is 83% versus 96% in your 24-week regimen. And these are compensated cirrhotics. The albumin of less than 35, you see is somewhat of a differential, however, not as profound as with a platelet differential. And then the alpha fetoprotein. So this is actually well captured in the European label and not so much in the Canadian and or US label. The US label will treat all the Geno 1As for an extended period of time. The Optimus 2 data is cimeprevir sofosbuvir in cirrhotics, and basically treated 12 weeks in cirrhotics as noribovirin. They captured treatment naive as well as treatment experienced patients. And as you would expect, if you look at the genotype 1A, if they have the Q80K polymorphism, there was a lower SVR. And interestingly, this was not seen in the Optimist 1, where they were the non-cirrhotic cohort only. But I want to pay special attention again to the platelet count in albumins. So the platelet count less than 90 versus greater than 90. Remember, these are the same regimens of 12 weeks, SimSof, 68% SVR and 87% SVR with the higher platelet count, acknowledging again smaller numbers of patients. Then looked also at the FibroScan score. Now, all centers did not utilize a FibroScan, and therefore there's less data with this again. But if you had a 20 kilopascal of FibroScan score, the SVR went down to 80%, versus if you had a 12.5 to 20 kilopascal reading, the higher SVR was achieved. So it looks like that we are subcategorizing persons who have cirrhosis to a more advanced cirrhotic potential. Let's move ahead to one of the drugs which is actually used the most at the present time for the genotype 1 patient. So this is the soft-lead combination. This is the ION-1 data, which is the pivotal trial for registry studies as well as the label findings for use of Harvoni. And this is looking at SVR12 data. And I'd show you just the cirrhotic cohorts, which is essentially the bars more on the right, the bars on the right side. 30 patients in each of the arms, which actually made up the label in these persons. This study incorporated patients' entry criteria of 12.5 kilopascals on a FibroScan, were less liberal on the platelet count, so you had to be greater than 90, and your albumin had to be greater than 35. Okay? And these are all obviously compensated cirrhotic patients. And we're left with a label that says use soft lead for 12 weeks in the cirrhotic patient because it seems equivalent to soft lead 24 weeks with or without ribavirin. In the summer, there was a study published by Raj Reddy and co-authors in Hepatology, which essentially took the phase 2 and phase 3 Gilead programs for soft lead, as well as incorporated the Cirrus study, which is from the French early access program of soft lead, and looked at over 500 patients with cirrhosis treated with soft lead plus or minus ribavirin with various durations of 12 or 24 weeks. So the duration 12 weeks without ribavirin, 12 weeks with ribavirin, as well as 24 without and 24 with ribavirin. In treatment-naive patients, essentially there wasn't much of a difference. Treatment-experienced patients, as you well know, you should use 12 weeks with ribavirin or 24 weeks without ribavirin or 24 weeks with ribavirin. That's not what I wanted to pay more attention to. What I wanted to focus on was, again, on this platelet count. So they subcategorized the platelet count in persons, platelets less than 75 and greater than 75. If you look overall, and these are reasonable numbers of patients, not high, but reasonable numbers of patients, 84% to SVR if they're less than 75, and 97% SVR. So again, maximizing your SVR is important. If you look at your treatment-naive patients, you see again a differential in the SVR, and it's more profound in your treatment-experienced patients. Unfortunately, what we don't have captured in this database is how the persons who fared with a treatment with ribavirin or the extended duration of soft lead, because that's really the question, is if you are treating those persons for a longer duration of time, who are your sicker cirrhotics, would you get a better SVR? So essentially going towards probably treating those ones with advanced cirrhosis, probably categorized or defined by a platelet count less than 90, as well as an albumin less than 35, as the reappearance has done, probably treating them as a decompensated patient, even though not truly decompensated at this time, may actually optimize your SVR. Let's shift thoughts a little bit and taking lessons from the same paper, looking at baseline NS5A RAVs. And we've heard a lot about the baseline testing, and I think the future is probably going to the context that one pill or a few pills will fit all sizes, and we're not going to really do any genotyping, forget about baseline resistance testing. But there may be some role in certain cohorts where you actually might consider optimizing again their SVR. So this is the same paper from Reddy and co., looking again at the phase 2 and phase 3 program, and they looked at the baseline NS5A RAVs, so patients with NS5A and patients without NS5A, and you could see the SVR overall was a bit lower in the persons with an NS5A RAV. Now remember, all these are cirrhotic patients, whether be it treatment naive or treatment experienced. They looked at the different treatment algorithms, so 12 weeks without ribavirin, 12 weeks with ribavirin, 24 weeks without and with ribavirin, and you can see that when you did add ribavirin, even if it was for 12 weeks, that the SVR rates went from 88% to 94%, and in the 24-week cohort went from 85% to 100%. So that there may be the context of using ribavirin in some of those patients, which may optimize, again, therapy. And obviously, these are cirrhotics, and if you are going to be using it for a different aspect, like the low platelet count, it may not be as benefit. And again, the whole context of baseline resistance testing and potency of these baseline RAVs is not really considered in this. So what do we do today for patients who are DAA failures? And when I talk about DAA failures, you're really only looking at two regimens with DAA failures. Either it's going to be the soft lead or the AV3D regimen, and less often they declare as well just utilization. It's a bit less based on cost, I think. The issue is really the persistence of these variants. So DAA failures, what is the persistence of the NS5A RAV or TEV? 95, 96% at week 48, and up to 86% persistence at week 96. And the NS5B, it's obviously this is only going to be from the AV3D program that we have these measures, 42% at week 48, and NS3 RAV, so the protease RAV, 7% at week 48. how do we treat them at this point? Well, fortunately, not very well overall. So this is data from Eric Lavitz, and it's the retreatment for the DAA failures utilizing 24 weeks of soft lead after failure of 8 to 12 weeks of soft lead, looking at the SVR 12 responses. 41 patients were treated in all. Again, SVR is on the y-axis. Persons with and without cirrhosis seem to fare the same, be it smaller numbers of patients overall. There was differences between 8 and 12 weeks of therapy, with persons at 12 weeks of prior therapy not doing as well, though these patients at 12 weeks who had failed previous 12 weeks of therapy had a high proportion of NS5A RAVs, which would lead to likely the lower response rate. The biggest predictor is the baseline NS5 RAVs prior to the next treatment. You see persons who did not have a RAD have a 100% SVR versus those who did have a RAV had a 60% SVR. If you take this a step forward, is the number of RAVs and type of RAVs important? So if you did not have a RAV, again, 100% SVR. If you did have just one, you get a higher response rate than if you did not have, than if you had more than one RAV. And is the type of a RAV important? It appears that the Y93 RAV is more important to predict a poorer response. The concern also highlighted in this paper was that 3 patients actually developed an NS5B RAV along the way, and 2 of them with the S282T. So utilizing just soft lead perhaps for 24 weeks is not effective, particularly if you have a baseline RAV. If you did not have a baseline RAV, it did look effective overall. There will be further data at the AASLD this year. So today or at this time, if you're retreating patients who have DAA failures, really it should only be considered if you have resistance testing available to you. I don't think it'd be optimal to treat if you did not have resistance testing available to you. You'd have to consider potential utilization of ribavirin, though with no sufficient data to really say this, aside from using the data shown you from Reddy's paper. Duration of therapy is probably important, and or maybe incorporating multiple DAAs, so throwing in the kitchen sink essentially. When you have a NS5A RAV, which is persistent, additional of protease into the mix. There'll be 2 late-breaking abstracts. One is treatment with failures with the 3D regimen and sofosbuvir. There's a bit of a mixed pattern with regards to the patients entering this cohort, so it's more challenging to make definitive arguments. And then with the C-SWIFT retreatment arm, so 12 weeks of the protease NS5A and SOF, as well as ribavirin, those patients who failed the previous shorter duration therapies. Shifting focus, let's look at the decompensated patient briefly. This is a SOLAR-2 study, so it's sofosbuvir, ladipsavir, plus ribavirin for 12 or 24 weeks. And you can see in genotype 1A and genotype 4, you get response rates in the high 80s. The concern really becomes, is the assays. I tell my patients there's a 30 to 50% chance they're going to end up in hospital, and there's a 5% death rate. So the question is, how do you really optimize a therapy when you're already looking at high assay rate as well as death rate? We don't see any differentiation between the 12-week and 24-week arms. However, if you do the simple math, there were some patients discontinued due to AEs, as well as patients that died on this regimens, and not due to the regimen, but died potentially of the natural history of this. And maybe doing a per protocol analysis for some of this data is also reasonable, because intention to treat may not always tell the whole story if patients actually not really completing the therapies. What I focus more on is now perhaps shifting away from treating those ones who are severely decompensated, so your child C certainly, even your child B, I've come to treat them less so at this point and actually transplant them first. It's not as easy just to get a transplant. You don't go to Safeway and get a liver, mind you. But treating them post-transplant may be another way to actually go if they have a high chance of getting transplanted. The concerns we've seen clinically is that when you're treating a patient who is a child B or child C, you're actually improving the liver function, and you downgrade their MELD. So when you're downgrading a person's MELD, you're taking them off a transplant list. And you may not have done them much of a favor, because some of these patients have significant ascites as well as encephalopathy, which is not clearly captured by MELD. And now you've downgraded them into this never land where they're suffering, they don't have a great quality of life, and now they can't even get transplanted easily because the MELD scores has improved to that level. So I think it takes prudent and careful consideration of who to treat in a child B or child C, or whether if they're high of the high chance of getting a transplant, perhaps progressing to a transplant earlier. I should note there was an advisory from FDA with a label change for the IV3D program, where the Child's B and Child's C essentially are contraindicated for their therapies, but you could still treat the extensive compensated patient. The Ally 1 program looked at the Decladisvir, another NS5A with sofosbuvir ribavirin for 12 weeks, and this just shows the data based on child CP score as well as albumin score, and you see the Child's B faring better than the Child's C, be it smaller numbers of patients. And again, you see this whole context of the albumin. Now the albumin is incorporated into the Child's C, and this may be confounded per se, but again, those ones with a low albumin score don't do as well, and maybe they'll require something different. Let's shift focus to genotype 2. So genotype 2 patients are probably thrilled at this point because they actually get their own couple of slides and not being melded into genotype 3 anymore. So genotype 2, what are the lessons learned in the last few months? This is a paper just published this month in Gastroenterology, but it's the boson study, which I know many of you are very familiar with. So the boson study for genotype 2 patients, sofosbuvir ledipsivir for 16 weeks versus soft-rib for 16 weeks versus soft-rib for 24 weeks versus peg-rib soft for 12 weeks. All patients entered into the study were cirrhotic and treatment experienced with peg-ribavirin previously. If we look at the SVR data, patients treated for 16 weeks had about 87% SVR, and it's higher for the 24-week cohort as well as the peg-rib soft cohort. Essentially, most guidelines and jurisdictions were utilizing 16 weeks for the retreatment capacities. Some were suggesting 20 weeks of retreatment, and maybe prudent now to push into 24 weeks if you're going to use just a soft rib in your patient who's compensated. The other consideration would be the peg-rib soft, which is a lot more cost attractive given just 12 weeks of sofosbuvir with, again, a very good SVR, and most patients will be able to tolerate 12 weeks of interferon-based therapy, obviously depending on their compensation status. What about genotype 3? Well, this is becoming the ongoing challenge in hepatitis C. Again, looking at the boson data, so again, in genotype 3, they were treated either for 16 weeks with soft ribavirin in the bluish-purple color, soft ribavirin for 24 weeks, or peg-rib soft for 12 weeks. It's characterized, again, SVR on the y-axis, characterized into treatment-naive patients. In the non-cirrhotic cohort, I'd only pay attention to the orange bar and the green bar. And you see there is some improvement by using peg-rib soft 12 weeks versus soft rib. Obviously, the confidence intervals are overlapping, but there is a numerical improvement. If you go into the cirrhotic cohort, what treatment naive, it's a 90% versus an 82%. And certainly this is, when you say a clinically significant difference, what is the clinically significant difference? I think most people would agree that a 5 to 7% benefit would be indicative of that, and certainly this is that. It doesn't meet my criteria, again, for the 95% cure in this cohort, but certainly is getting into the 90% cohort. If we look at your treatment experienced patients, non-cirrhotic, soft rib for 24 weeks, 80% SVR, and the peg-rib soft cohort, 94% SVR. Where it's again challenging is your treatment experienced cirrhotic patient, and the soft ribavirin for 24 weeks is a 77% SVR, and your peg-rib soft goes up to 86%. So not hitting quite your benchmark of 90%, but certainly better than the 77% you get. So again, this is more indicative of what regimens we should be using for patients with genotype 3. Unfortunately, a lot of this really depends on your jurisdiction. In Canada, we don't have peg-rib soft license, so I cannot get peg-rib soft. However, I can get soft ribavirin for 24 weeks for this particular patient. So we are using sometimes suboptimal therapies, more jurisdictionally based or payee based as opposed to data based, I think. Hopefully things would change a bit. The Ally 3 data is the Decladisvir, so NS5A plus sofosbuvir for 12 weeks. Note there's no ribavirin. Looking at treatment naive or treatment experienced patients, included cirrhotics as well as non-cirrhotics. Look, the blue bar is the non-cirrhotics. And you can see in treatment naive as well as treatment experienced patients, SVR rates in the mid-90s. This therapy is not very good for your cirrhotic patients, though. But 12 weeks of Decladisvir sofosbuvir for the non-cirrhotic cohort seems to do well. We take lessons from the Europeans again with regards to compassionate access programs. They are utilizing sofosbuvir Decladisvir for the genotype 3 patients for 24 weeks And if you look at your cirrhotic cohort here, 12 weeks versus 24 weeks, and you can see a high proportion of SVR in the 24-week arm versus the 12-week arm. These were predominantly treatment-experienced patients as well. An abstract will be presented on Monday at AASLD, so this is just data from the abstract itself. It's only looking at the SVR4 data, where they will be presenting the SVR12 data. This is the Ally 3+, so it's going to be the Declarazivir plus sofosbuvir plus ribavirin. So there's addition of ribavirin in this regimen for 12 or 16 weeks in the genotype 3 patients, either cirrhotics or they're going to be advanced fibrosis. 50 patients, 74% were treatment experienced and 72% had cirrhosis. They also included a few patients, 10%, which were previously soft ribavirin failures. And these are the SVR4 data. So in the 12-week arm versus the 16-week arm, you see in patient advanced fibrosis, they did well, though they're very few numbers. In the cirrhotic patient, the 12-week arm seems not to do as favorably as the 16-week arm. Again, I would mention this is SVR4 data. We're not getting virologic breakthroughs in this, and nor did we see many virologic breakthroughs in the boson study. The only 3 virologic breakthroughs. Patients are relapsing more than anything else in these regimens. Again, so then the optimal therapy, at least at this point, would probably be soft declarazivir and ribavirin for 16 weeks in your patients who are cirrhotic, even if they're treatment experienced. In summary, today's regimens, which you can utilize to probably optimize the SVR, I think we should consider the whole context of the advanced cirrhotic patient, and everybody's going to probably define it a bit differently. I think the European label probably defines it conservatively and well, looking at platelets less than 90, and perhaps an albumin component at 3.5 or 35 in Canada. There's an alpha-fetoprotein category of greater than 20, which comes from the Turquoise II data. And those patients should probably be treated more aggressively, similar to how we would treat the decompensated patient, maybe adding ribavirin to a soft-lead 12-week regimen or giving them soft-lead for 24 weeks. When regimens fail, I know it's few and far between, but we are looking at some categories between 5 and 10%, the utilization of testing for NS5A variants. The role of ribavirin, well, may still be in there. The duration of therapy seems to be important to some degree. And again, throwing the kitchen sink is never a bad thing when all else fails, and adding a few DAIs with higher potency. In genotype 2, I think shifting in the treatment experience, cirrhotic patient, soft ribavirin for 24 weeks is probably the best aspect of therapy, or considering PEG-RIB soft for 12 weeks, depending on the cirrhotic status of the patient. And in the genotype 3, non-cirrhotic patient, soft declarazivir for 12 weeks seems to give you a robust response, whether you are naive or treatment experienced. And in your patients who are cirrhotic, addition of ribavirin to soft declarazivir for 16 weeks, or potentially using PEG-RIB soft for 12 weeks. Thank you very much.